You glance down and something looks off. Maybe it is darker than it should be. Maybe there is a color you do not quite recognize. And now you are wondering, is that normal for me, or is this something different, something connected to what is already happening inside my body? Here is what most people with lupus or Sjögren's do not realize. Your kidneys are one of the most targeted organs in both of these diseases. And your urine is one of the earliest windows into what is actually going on in there. So today I am going to walk you through what normal looks like, what dangerous looks like, and the specific changes that matter most if you are living with lupus or Sjögren's. By the end you will know exactly what to brush off and exactly when to pick up the phone. Before we get into the warning colors, you need to understand something simple about why this matters more for you than it does for the average person. Urine is filtered blood. Your kidneys take roughly 180 liters of fluid from your bloodstream every single day, and most of it goes straight back in. What comes out is waste, electrolytes, and a yellow pigment called urochrome, which is produced naturally when red blood cells break down. The amount of urochrome you produce each day stays fairly constant. What changes is how much water goes in. Less water means darker urine. More water means paler urine. That part is the same for everyone. But here is where lupus and Sjögren's change the picture entirely. Both conditions can directly attack the kidneys. In lupus, the immune system can inflame the kidney filters in a process called lupus nephritis, which affects up to 60% of people with systemic lupus at some point in their life. In Sjögren's, the kidneys can also be targeted, with the tubules, the tiny channels that move fluid through the kidney, becoming damaged in a pattern called tubulointerstitial nephritis. Neither of these always announces itself with dramatic pain. They can be quiet. And that is exactly why what ends up in the toilet bowl deserves your full attention. If that sentence just landed for you, if something in what I've described so far sounds familiar, I've put together a symptom map that shows exactly how this condition progresses, what shows up at each stage, and where the standard tests are most likely to miss it. Type symptom map in the comments right now and I'll send it to you directly. Because what I'm about to show you next is why that map matters more than most people realize, and why the stage you're in changes everything about what happens next. Number 1. Red or pink urine. This is the one that gets the most attention, and for very good reason. Blood should stay in the circulatory system. It belongs inside the pipes, not in what comes out of them. If you see red or pink urine, something somewhere in the filtration system has broken down and blood is finding its way where it should not be. The medical term for blood in the urine is hematuria. It can be visible to the naked eye, which is called gross hematuria, or it can be present in tiny amounts only detectable under a microscope, which is called microscopic hematuria. Both matter. Both deserve investigation. In someone without an autoimmune condition, blood in the urine can come from a urinary tract infection, a kidney stone, vigorous exercise, or in more serious cases, a problem with the bladder or kidney. Those explanations can still apply to you. Having lupus or Sjögren's does not make you immune to kidney stones or UTIs. But in the context of these conditions, there is an additional layer of concern that changes the urgency entirely. Research and clinical guidelines confirm that hematuria, particularly when found alongside protein in the urine, is one of the primary indicators of active lupus nephritis and of glomerular involvement in lupus kidney disease. The KDIGO guidelines on lupus nephritis emphasize that kidney involvement can remain silent or asymptomatic for significant periods even while ongoing inflammation is causing damage. The severity of what is found in the urine does not always match how a person feels. Severe active nephritis can sometimes present with relatively minimal urine changes, and even those minimal changes matter. Microscopic hematuria can be the first sign of lupus nephritis before anything else surfaces. Here is what that means for you practically. Red or pink urine that you can see with the naked eye is not a wait-and-see situation. It is not a let me drink more water and see if it goes situation. It is a same-day phone call to your rheumatologist or care team. Today. And if you cannot reach your team today, that is urgent care territory. You do not postpone this. Not because it will definitely turn out to be something serious. It may turn out to be a straightforward UTI. It may clear with simple treatment. But the only way to know that is to get checked. The cost of finding out it was nothing is a single appointment. The cost of assuming it is nothing and being wrong is potentially months of kidney damage that was accumulating while you waited. There is also something important to understand about hematuria in lupus specifically. The research shows that lupus nephritis is a risk factor for UTIs in people with lupus, partly because of the kidney involvement itself and partly because the immunosuppressive medications used to manage lupus lower the body's defenses against bacterial infection. So even if the cause turns out to be a UTI, that UTI in the context of your condition needs to be taken seriously and treated promptly rather than left to resolve on its own. Type the word blood in the comments if this is something you have seen before or if this is the first time anyone has connected hematuria directly to your condition. Your comment might be exactly what someone else in this community needs to see today. Number 2. Brown or cola-colored urine. Dark brown urine sits in a different category to red or pink urine and deserves its own explanation because the two can look similar at first glance but mean very different things and come from different processes inside the body. The first explanation for dark brown urine is straightforward and applies to everyone. If you are severely dehydrated, your urine will become very concentrated and can shift toward a dark amber or brown color. For people with Sjögren's in particular, dehydration is an ongoing risk. The reduced saliva production that characterizes Sjögren's is not just about dry mouth as an inconvenience. It is a sign that the exocrine glands throughout the body are under immune attack and producing less fluid than they should. Between 70 and 80% of people with Sjögren's report significant dry mouth. When you are not producing enough saliva, the natural thirst signaling and fluid intake patterns that keep most people hydrated can be disrupted. Many people with Sjögren's are chronically running on the drier side without fully realizing it, and that alone can push urine toward darker, more concentrated colors. So the first question when you see brown urine is always, have I been drinking enough fluids? Increase your water intake steadily and monitor over the next several hours. If the color begins to shift back toward yellow or pale amber with hydration, dehydration was likely the primary cause and you should use it as a prompt to look more carefully at your daily fluid intake going forward. But there is a second, more serious explanation for brown urine that is specific to the context of lupus kidney disease. When the kidney filters have been under prolonged immune attack, damaged glomeruli can allow red blood cells to enter the urinary system and break down within it. The pigment released during that breakdown process, called hemoglobin, shifts the color of urine toward dark brown or even black rather than the fresher red or pink of intact blood cells finding their way through. This type of brown discoloration looks different from the concentrated dark amber of dehydration. It tends to be a warmer, deeper brown, sometimes described as cola or tea-colored. It can appear without pain. It can appear at a time when you feel relatively stable. And it can indicate that the kind of kidney damage happening is occurring deeper within the filtration system than fresh blood in the urine would suggest. The approach with brown urine is always to hydrate first and then watch. If it clears with steady hydration over the course of a day, reassess and consider whether your fluid intake needs to improve consistently. If it does not clear with hydration, or if you feel unwell alongside it, fatigue beyond your normal baseline, weak, nauseated, or dizzy, you contact your care team the same day. And if you genuinely cannot tell whether what you are looking at is dark amber from dehydration, dark brown from a more serious process, or something in between, do not try to work it out on your own. Get checked. Color assessment is not a diagnostic tool. A urine test is. Type the word cola in the comments if you have ever dismissed a dark urine change because you told yourself you just needed to drink more water, and you want to remind yourself to take it more seriously from now on. Number 3. Foamy urine. This is one of the most important urine changes for this community, and it is also one of the most quietly overlooked because it does not look dramatic. Foam does not look like blood. Foam does not look like something is obviously wrong. Foam looks like bubbles in the toilet and most people assume it is just the force of the stream hitting the water, and sometimes that is exactly what it is. A single occurrence of foamy urine, particularly first thing in the morning when urine is more concentrated, or when the stream has more force behind it, is often completely harmless. One bubble or a brief froth that disappears within seconds is usually not a concern. What you need to pay attention to is persistent foam. Foam that comes back every time you look over the course of several days. Foam that sits in the toilet and takes more than a few seconds to dissipate. Foam that is present whether your urine is concentrated or dilute. That kind of foam is one of the key early warning signs of protein leaking through damaged kidney filters into the urine, a process called proteinuria. Here is why protein matters. Protein, primarily albumin, is supposed to stay in your bloodstream. The kidney filters are designed to keep protein in circulation while letting waste products pass through. When the filters are healthy, almost no protein makes it into the urine. When the filters are inflamed, damaged, or scarred, they become leaky. Protein begins to spill through and ends up in the urine. When protein is present in significant amounts in the urine, it creates surface tension in the water that produces foam, much like soap creates foam. And that foam is visible to you without any equipment, without any test, without any appointment. It is sitting right there in the toilet telling you something. Proteinuria is one of the central diagnostic and monitoring markers for lupus nephritis. Clinical sources including StatPearls and Cleveland Clinic confirm that foamy urine caused by proteinuria is one of the early indications of lupus nephritis, appearing alongside or even before other signs of kidney involvement. In Sjögren's, proteinuria can also appear when tubulointerstitial nephritis has been progressing in the background, particularly if glomerular involvement has developed alongside the more common tubular damage. And in both conditions, the proteinuria can be present before you feel any notable change in how you are doing day to day. The action here is clear. If you notice persistent foam coming back over several days, the single most useful thing you can do is bring an early morning urine sample to your next appointment or contact your care team to discuss it sooner. Early morning samples, the very first void of the day before eating or drinking anything else, are the most concentrated and give the clearest picture of what your kidneys are doing. A simple protein to creatinine ratio test on that sample gives your care team real information fast. This is not an emergency requiring a same-day call in the way red blood does, but it is also not something to note in the back of your mind and never act on. Persistent foam over several days is a prompt to make contact. Type the word foam in the comments if foam in your urine is something you have noticed before but never knew could be connected to your condition. Your comment matters because someone else in this community is reading it right now and wondering whether to do something about theirs. Number 4. Cloudy urine with symptoms. Cloudy urine on its own, without any accompanying symptoms, is often not a major concern. Urine can appear temporarily cloudy from being highly concentrated, from harmless mineral deposits, or from small amounts of mucus. If you see cloudy urine one time and feel completely fine in every other way, increase your fluids and reassess the following morning. If it clears, move on. But cloudy urine combined with other symptoms is an entirely different conversation. If your urine is cloudy and you also have burning or stinging when you urinate, a feeling of needing to go urgently or more frequently than usual, discomfort or pressure in the lower abdomen or pelvic area, or urine that has an unusual or stronger odor than normal, that combination points toward a urinary tract infection. And in the context of lupus or Sjögren's, a UTI is not a minor inconvenience to push through. It is something that needs same-day contact with your care team. There are two specific reasons why UTIs carry more weight in this community. The first is that research confirms lupus nephritis itself is a risk factor for UTIs in people with lupus. When the kidneys have been inflamed or damaged by the immune response, they become more vulnerable to bacterial infection taking hold. The second reason is medication-related. Both lupus and Sjögren's are commonly managed with immunosuppressive drugs, including hydroxychloroquine, methotrexate, mycophenolate, azathioprine, and Inflair's corticosteroids. These medications work by dampening the immune response that is causing damage. But they also reduce the body's ability to fight off infections before they escalate. A UTI that might clear quickly in someone without immunosuppression can take hold faster and spread more aggressively in someone whose immune response has been deliberately reduced. A UTI that reaches the kidneys in someone with already vulnerable kidneys is a significantly more serious situation than the same infection in someone without that underlying vulnerability. So the rule is clear. Cloudy urine plus any of those accompanying symptoms means same-day contact. Not a wait and see. Not a try more water first. Same-day contact. Cloudy urine completely on its own with nothing else is a watch and hydrate situation. But the moment symptoms are present alongside it, you reach out. Type the word cloud in the comments if UTIs have been a recurring issue for you since your diagnosis or since starting immunosuppressive treatment. Tell me how frequently they have been happening and whether your care team has addressed it as a pattern. Number 5. Persistent foam without other symptoms. This section deserves to sit separately from the foamy urine section, because the experience of persistent foam without anything else feeling wrong is its own specific situation that a lot of people in this community find themselves in. You feel reasonably stable. You are not having an obvious flare. Your joints are manageable. Your fatigue is at its usual baseline. And yet every time you look at the toilet there is foam that takes a while to clear. Nothing else seems wrong. And so you do nothing, because without a symptom that is obviously pushing you to act, the foam just becomes part of the background noise of your day. This is one of the most important mistakes to avoid. Proteinuria, which is what the foam is indicating, does not require you to feel sick to be present and progressing. Research from peer-reviewed sources confirms that in the early stages of lupus nephritis, patients are frequently asymptomatic. Some people are only identified as having significant kidney involvement when routine monitoring catches abnormalities in their urine or blood tests. Proteinuria can be present and accumulating for months before anything in how a person feels signals that something is wrong. And every month that passes with unaddressed proteinuria is a month that the filtration units of the kidney are under strain. This is why monitoring matters and why you need to be an active participant in your own monitoring rather than waiting for your care team to raise it. At your next rheumatology or nephrology appointment, if routine urine testing has not been done recently, ask for it directly. Ask specifically for a urine protein to creatinine ratio, which is done on a single sample rather than requiring a 24-hour urine collection. Ask what your last result was and what the trend has been over time. If you have had results that were slightly elevated and no one followed up on them, raise that. Ask what the threshold is at which action would be taken and where your numbers currently sit relative to that threshold. Early morning samples are the most accurate for this. First thing in the morning, before food or drink, is when your urine is most concentrated and the protein to creatinine ratio reflects what your kidneys are doing in their overnight resting state most clearly. If foam is something you are seeing consistently and you have not had a urine protein check recently, that is your next step. Bring an early morning sample to your next appointment without waiting to be asked. Type the word protein in the comments and tell me whether protein monitoring has been a consistent part of your care or whether it has come and gone depending on which appointment you had and who you saw that day. Number 6. Brown urine and the Sjögren-specific electrolyte picture. There is an additional dimension to brown and dark urine in Sjögren's that is worth understanding separately because it connects to something that often goes unrecognized in this community entirely. When tubulointerstitial nephritis is present in Sjögren's, one of its most significant consequences is distal renal tubular acidosis. This is where the tubules of the kidney lose their ability to properly regulate acid-base balance in the body. The result is that acid accumulates in the blood while the urine becomes inappropriately alkaline, and potassium can be lost excessively through the urine as part of that disrupted electrolyte management. What this means in terms of what you might observe is that the urine can shift in color and character in ways that reflect not just hydration but underlying tubular dysfunction. Urine that appears persistently dark despite adequate fluid intake, urine that appears unusually clear or oddly alkaline in smell, or urine changes that accompany unexplained muscle weakness, cramps, fatigue beyond your normal baseline, or episodes of unusual physical tiredness, can all be connected to this tubular dysfunction rather than to simple dehydration or to blood. Multiple case reports and research papers document patients with Sjögren's whose kidney involvement presented first through muscle weakness and urine changes before the classic dry eye and dry mouth symptoms became prominent. In some patients the kidney involvement preceded the glandular symptoms by months or even years. This matters because it means your urine is potentially reporting on kidney function even when your Sjögren's seems otherwise stable or well controlled. If you are noticing persistent dark urine that does not match your hydration levels, or if you are experiencing unexplained muscle weakness or fatigue alongside any urine changes, those two pieces together are worth raising explicitly with your care team. Ask whether your electrolytes including potassium have been checked recently. Ask whether a urine pH test or urine anion gap has ever been done to look at how your tubules are handling acid regulation. These are not exotic tests. They are straightforward blood and urine checks that can reveal tubular dysfunction that would otherwise remain invisible. Type the word tubes in the comments if this is the first time you have heard that Sjögren's can affect the kidneys in this way, through tubular damage rather than through the same mechanism as lupus nephritis. Number 7. Orange urine. Orange urine tends to produce alarm when it appears, and in most cases in this community the explanation is manageable. The most important first question when you see orange urine is, what have you recently put into your body? Certain medications that are used in the management of lupus and Sjögren's are well-documented causes of orange or orange-amber urine. Sulfasalazine, which is sometimes used for joint involvement in lupus, is a known culprit. If you are taking sulfasalazine and your urine has shifted toward orange, that is a medication effect worth mentioning to your prescriber, but it is not an emergency. High-dose B vitamins and certain supplements can also shift urine color toward orange or bright yellow. A urinary analgesic medication called phenazopyridine, which is sometimes given short-term for urinary pain relief during a UTI, produces a very striking orange or reddish-orange color that can be alarming if you were not warned it would happen. If you have recently started a new medication, increased a dose of an existing one, or added a new supplement and your urine has shifted toward orange, trace it back to what changed in the last week or two before reacting. Mention it at your next contact with your care team. If you cannot trace it to anything you have recently introduced, if it is not related to any medication change, and if it persists beyond a few days, then it warrants a conversation with your care team sooner. And if orange urine is accompanied by anything else that concerns you, particularly any pain in the lower back or side, or if it appears during a period when your lupus or Sjögren's has been more active, do not wait. Get it checked. Type the word orange in the comments if a medication has ever changed the color of your urine and no one warned you in advance that it would happen. It is more common than it should be. Number 8. Clear or very pale urine. Most urine education focuses on dark colors as the warning signs, and that is appropriate. But completely clear urine, urine with no yellow color at all that looks entirely like water, is also worth a brief mention because it sits at the opposite end of the spectrum from dehydration and can have its own implications. In most cases very clear, water-like urine simply means you are very well hydrated or have had a high fluid intake in a short period. Drinking large amounts of water quickly will dilute the urochrome pigment until the urine appears clear. That is not dangerous in a one-off situation. But if your urine is consistently and persistently clear over days despite a normal fluid intake, it can indicate that the kidney tubules are not concentrating urine properly. In Sjögren specifically, one of the recognized complications of tubulointerstitial nephritis is something called nephrogenic diabetes insipidus, where the tubules lose their ability to respond to the hormonal signal that tells the kidneys to concentrate urine. The result is very high volumes of very pale or clear urine even when you have not been drinking excessively. This can lead to significant fluid and electrolyte losses and contributes to the chronic dehydration risk in Sjögren's. If you notice that you are producing very large volumes of very pale or clear urine consistently, particularly if you also feel thirsty much of the time despite drinking enough, that pattern is worth raising with your care team as part of a broader kidney function assessment. Type the word clear in the comments if this is a pattern you have experienced and wondered about. Number 9. What to do if you are not sure what you are looking at. One of the most common situations people describe is looking at their urine and genuinely not knowing how to categorize what they are seeing. Is that dark amber or is that brown? Is that faintly pink or is that just the lighting? Is that foam from the stream or is that protein foam? And the answer to all of those questions is the same answer. If you cannot tell, you get it checked. Not because every ambiguous urine color is a crisis. Most of the time it will not be. But because the difference between those colors matters, and you do not have the equipment at home to distinguish dark amber from dark brown that is caused by hemoglobin, or to tell the difference between incidental foam and foam that is signaling proteinuria. Your care team has the equipment. A simple urine dipstick test takes seconds and gives real information. A urine protein to creatinine ratio takes a single sample and provides a clearer picture. A full urinalysis gives a comprehensive view of what is in your urine and what is not. The threshold for getting checked should be lower for you than it is for most people. Not because you need to be anxious or reactive about every change, but because you are in a high-risk category and the conditions you are living with have a documented pattern of quiet kidney involvement that reveals itself through urine before it reveals itself through symptoms. Using that information is not being dramatic. It is being sensible. Type the word check in the comments if you have ever talked yourself out of calling your care team about a urine change, because you were not sure it was serious enough to mention. Now here is the pattern that ties all of this together and the most important thing I want you to take away from this video. Lupus and Sjögren's are systemic diseases. They do not stay in one place. They can reach the kidneys, and when they do, they often do it quietly. The information your body produces every single day in the form of urine is one of the most accessible early warning systems you have. It costs you nothing to look. It costs you nothing to notice. And the habit of paying attention, the habit of glancing down and registering whether something looks different today than it did yesterday, is a genuinely protective habit that could catch something early that would otherwise go unnoticed for months. Most people in this community have never been told this in a way that sticks. They have been told to come back in 3 months and get their bloods done. They have not been told that the toilet bowl is giving them information every single day in between those appointments. Now you know. And now you can use it. If this video helped you understand something about your body that no one has explained to you clearly before, our Sjögren symptom map is the next step. It breaks down exactly which organs are at risk in lupus and Sjögren's, which early signs to track and what they mean, what to bring to your next appointment, and how to have a more informed conversation with your care team about monitoring that matters. The link is in the description. Use it. Take it with you. It was designed for this community specifically because the standard patient materials do not go far enough. In the next video we are going into something else that most people in this community overlook completely, something that is visible every single day and that most people have never thought to connect to their condition. Once you understand it, you will not be able to unsee it. Make sure you are subscribed so you do not miss it when it goes up.